Hello, and welcome to another session of Learning Orthodontics the Easy Way, over a cup of coffee. I'm Ji Dae-kyung, the Senior Ortho Barista.
And I'm Lee Jungkook, the Junior Ortho Barista.
This year, we kicked off Ortho Barista, and we've already reached our 10th session. Time really flies, doesn't it?
Absolutely. There's something special about reaching the 10th session. So, for today, we've invited a very special guest to join us. Please come on in.
Great to have you here.
Welcome.
Hello, I'm Youngkwon Choi, and I'm excited to share a lot with you today on Ortho Barista.
This is your first time in our studio, isn't it? How do you find it?
Oh, it's absolutely stunning. I was honestly blown away by how impressive it is. Thank you so much for inviting me to such an amazing space.
We're truly grateful to have you at our cafe. And since we have a special guest today, we have prepared a special coffee treat for you. All right then, everyone together now. 1, 2, 3.
커피 한잔 할래요?
Oh, should we add harmonies?
커피 한잔.
1, 2, 3, 4.
커피 한잔 할래요? 커피 한잔 할래요?
Fun fact is that it turns out both of these gentlemen were in a choir.
Both as tenors.
Today's special coffee is Barraquito, a Spanish coffee cocktail. And yes, being a cocktail, it does have a bit of alcohol in it. Both of you seem to enjoy this kind of thing, right?
I honestly thought we'd be transported straight to Spain for this. It's our 10th episode, so I guess a little celebratory drink might be okay. Shall we get started and make it together? Let's start with condensed milk. Add as much condensed milk as you like. We love sweet things.
Me too, childhood palate here, so I'll add a lot.
Wow, that's quite a lot. Well, I've had a sweet tooth like a kid, so I am going to add a generous amount.
Next, let's add the orange liqueur. Feel free to adjust it to your taste, just don't overdo it.
That's enough.
I put it all in.
After that, we pour in the cold brew coffee. The ratio of condensed milk, liqueur, and cold brew is 1 to 1 to 5.
If I mess this up, I'll get labeled as a surgeon with no dexterity.
Looks like you've got the touch.
Surgeons really are a step above, huh? Alright, now let's create some foam.
Give it a gentle stir, and let's have a taste together. 1, 2, 3.
Barraquito!
Wow, this is delicious.
Absolutely amazing.
It feels like walking along a hot beach and then grabbing a cold beer, just perfect. So refreshing.
The hint of alcohol really adds to the good vibes. Now, this feeling, let's start with our easy orthodontic treatment session. So, let's officially start Easy Orthodontics with Dr. Lee Jung-guk, Dr. Ji Dae-kyung, and our guest Dr. Choi Young-kwon.
For those watching on the Dental website, feel free to post your questions in the chat box. We'll do our best to answer your questions, and selected participants will receive Starbucks coffee coupons through a raffle.
All right, let's dive into today's topic, intraoral minor surgeries and orthodontic treatment. This might be a topic of great interest not only to orthodontists, but also to general dentists who are watching this broadcast. Let's approach this with excitement and focus.
Today's topic explores various types of minor intraoral surgeries that can complement orthodontic treatments. We'll explore how these procedures can be applied to orthodontic treatments and how to approach them effectively. Instead of a lecture-heavy format, we'll show you multiple videos. Think of this as watching YouTube casually rather than attending a lecture. This patient was referred to me by an orthodontist for tooth extraction.
This X-ray might look quite familiar. It seems to be from quite a while ago.
Probably around years old. This case involved Dr. Lee Jung-kook, who is here, who referred the patient for the extraction of an impacted tooth before starting orthodontic treatment. Fortunately, the extraction went smoothly without any nerve damage or major complications. The patient was referred back to Dr. Lee for orthodontic treatment, which was successfully completed.
If I recall correctly, this patient had severe crowding in the lower arch, and the plan was to distalize the number 6 tooth to create space and address the crowding. Are you going to share the techniques used in such cases today?
Not exactly. Just because I mentioned it briefly, it doesn't mean we should casually extract a tooth and proceed that way. The point is to show that such cases can be solved by effective collaboration between orthodontists and oral surgeons. That is why I show such cases with successful outcome.
To manage such a complex case, it's clear that you're a highly skilled surgeon. We're looking forward to today's lecture.
The first topic involves premolar extraction cases, which are among the most common in orthodontic treatment. Earlier, we saw a challenging case with impacted teeth. While simpler cases can often be managed in-house, deeply impacted teeth are typically referred to specialists. However, when it comes to premolars, these are generally straightforward extractions that even orthodontic residents can handle with ease. I've prepared a basic video to demonstrate this process. When it comes to extractions, the most fundamental thing I emphasize is the use of forceps. During our residency training, we often saw those using elevators to quickly extract teeth. However, elevators are not designed for extraction, they are tools used to luxate teeth. Therefore, when extracting teeth, it's essential to use forceps correctly. One thing I always stress is to hold the forceps with all your strength, as if you're gathering all the energy you have. For patients with short roots or low bone density, simply gripping the tooth firmly with the forceps can cause the tooth to pop out easily. That's how effective a strong grip can be.
It's not about shaking or wiggling the forceps aggressively, but simply gripping tightly.
Sometimes, just gripping the tooth firmly can cause it to come out immediately.
That can happen, especially with premolars, and it's also quite common when extracting wisdom teeth. So, the most critical part is how you grip the forceps, but this applies only to vital teeth. In the case of non-vital teeth, the moment you grip them, they can shatter into pieces with a cracking sound. In those cases, we describe it as applying the right amount of force. There's no definitive answer, but I'd say as firmly as possible without causing the tooth to fracture. Once again, I want to emphasize that gripping the forceps firmly is crucial. When using the forceps like this, you'll need to wiggle the tooth. Textbooks suggest moving it buccolingually, but I tend to wiggle it in various directions rather than just buccolingually. If you apply rotation, single-rooted teeth come out easily. But with multi-rooted teeth, the roots may fracture. Instead of rotating, try to wiggle it gently in multiple directions. If you feel hesitant about gripping and wiggling from the start, you can use a thin diamond burr, like the ones used for prosthetic prep, to open the mesial distal contact before grabbing the forceps and wiggling. That way, it can come out quite easily. Maxillary teeth are generally easier to extract, but they often have 2 roots. So, you need to be cautious about root fractures. Grip it firmly, open the mesial distal contact, and gently wiggle with the forceps to achieve good results. Mandibular teeth are often single-rooted. However, the bone density in the mandible is significantly stronger than in the maxilla because there's more cortical bone, which makes extractions slightly more challenging. Still, the same principle applies. Grip firmly with the forceps, and gently wiggle the tooth to extract it. If you feel unsure, you can use a thin diamond burr to open the contact points before proceeding with the extraction, which can make the process much easier.
By the way, this reminds me, how do you handle post-extraction medication prescriptions? Premolar extractions sometimes don't require medication prescriptions, but I'd like to hear your opinion on this. In the case of orthodontic extractions for teenagers where the procedure is quite straightforward, how should medication prescriptions typically be handled?
There's always a lot of debate around prescribing medication after extractions. It's a controversial topic, and being controversial often means there isn't a clear consensus on it. So, I believe it's important to consider various medical environments and adapt accordingly. In the context of Korea's healthcare environment, I personally think it's generally better to prescribe medication, although not excessively or unnecessarily. For basic premolar extractions, whether for orthodontic purposes or general cases, amoxicillin and Tylenol AAP are sufficient to cover most situations. In fact, not only for premolars but for the majority of extractions, these two medications generally suffice. I believe medication should be prescribed, but not excessively. However, if there are signs of pericoronitis or acute or chronic infections in the surrounding area, adjustments should be made. In such cases, prescribing Augmentin or a broader spectrum antibiotic might be necessary. In essence, my approach is to prescribe antibiotics or pain relievers when necessary, but to do so in moderation.
Even for such simple extractions, there's plenty to discuss.
Since we've prepared a lot, let's move on to the next topic.
The next procedure is alveoloplasty. Let's take a look at a straightforward and conventional alveoloplasty procedure video. As you can see, this patient is nearly years old and has a history of severe clenching. Along with clenching, they also experience bruxism.
These conditions seem to be somewhat related to the bone spicule or exostosis issues that Dr. Lee Jung-ho mentioned previously.
Yes, indeed. When performing orthodontic treatments, you often encounter protruding spicules, don't you? If these are extensive and quite pronounced, you'll need to elevate a flap and remove them in a manner similar to what we're discussing now. In this patient's case, food kept getting trapped in the area, leading to necrosis and repeated inflammation. After a consultation, we discovered that their wisdom tooth was also decayed, causing occlusal interference with the opposing tooth. Since the anterior guidance was causing occlusal interference, I explained to the patient, we'll remove the wisdom tooth and also take care of the protruding spicules. Since all of this is covered by medical insurance, the patient won't face a significant financial burden. When making an incision, always start from the posterior and move towards the anterior. It is because, as you can see, the blood flows backwards. The patient is lying down. So if you start the incision from the anterior, the bleeding will obstruct your view as you try to extend the incision forward. Always remember, posterior to anterior. Additionally, there's the mental nerve located below, so never make a vertical incision recklessly in this area. Another important consideration is the region with a torus or overgrown alveolar bone. In these areas, the fibrous tissue tends to adhere very strongly, making flap elevation particularly challenging. When elevating the flap, if you rush, there's a high chance the flap will tear. This also applies to cases with bone spicules or exostosis. Be careful during flap elevation. Stay calm and patient. If not, the flap might tear. As you can see here, it is already torn. As you can see here, the flap is torn. When this happens, healing becomes more challenging. While it does eventually heal, thanks to the body's incredible and boundless regenerative abilities, it takes longer than if the tissue had remained intact. Once the area is fully exposed, you can proceed with the removal. For this, you can use a high-speed handpiece, or if you're concerned about emphysema, opt for a low-speed handpiece. In this case, you can see we're using a carbide burr. Using a carbide burr with a low-speed straight handpiece under continuous saline irrigation is also an excellent approach. Emphysema has been a topic of discussion for a long time, with related studies dating back to the 1950s and 1960s. However, due to the occasional medical disputes surrounding it, there has been renewed focus on the issue in recent years. In the past, I frequently used high-speed handpieces, a habit I've retained even now. While I still prefer high-speed instruments, you must always be cautious about emphysema. If you're concerned about it, I recommend using low-speed instruments instead.
Despite the significant amount of bones being removed, the bleeding is not as excessive as one might expect.
Correct. It is not as severe. Most exostoses or overgrown tori are primarily composed of cortical bone. Since cortical bone does not have an abundant blood supply, even when a significant amount is removed, it doesn't result in substantial bleeding. It's essential to remove enough bone, but the critical question is always, how much is enough? One tip I use, as shown in the video later, is to place the flap back and feel it with your fingers. After placing the flap, run your fingers over the surface to check for any irregularities. This tool is a bone file, which functions like sandpaper to smooth out rough areas. Using the bone file, refine the surface appropriately. Then, place the flap back, press with your fingers, and if there are still rough spots, you can further adjust by trimming more bone and filing. As you can see, I'm pressing the flap and checking with my fingers. If it feels smooth and acceptable, you can stop further bone reduction. For tooth extraction, as mentioned earlier, firmly grasp the tooth with the forceps and use movements in various directions to remove it.
In older patients, teeth can sometimes be very firmly attached and difficult to extract.
But often, if you grip the tooth tightly, it will come out. The key is a firm grip. Now this is a figure 8 suture. Start by inserting the needle from the papilla, and do same things to the lingual side, forming a tie. And when viewed in cross-section, the suture forms an 8 shape. Once again, the needle is inserted from the papilla. Then pass it through the embrasure. On the lingual side, the flap is opened and the needle is pulled outward before being reinserted into the papilla from the lingual side. In cross-section, once tied, it creates pressure on both the buccal and lingual sites, reducing any looseness of the flap.
It feels like it's been a while since I last performed a suture. This feels quite unfamiliar.
I remember when Dr. Jungkook Lee was an intern. One time, while he was on duty in the emergency room, he called me about performing a tongue suture. It was around 2 a.m., and he was so excited.
I had sutured the tongue for 3 hours, but the next day, it all came apart.
I still recall how thrilled he sounded, saying, "I did it." After completing the clean suturing, it's important to thoroughly irrigate the area. That's how you finish it up. You can certainly remove exostosis or hypertrophic cortical bone like this, but it can feel quite overwhelming, right? If it feels burdensome, you can always refer the case to an oral surgeon nearby. And it doesn't necessarily have to be an oral surgeon. There are many skilled dentists who may not have formal surgical training but are excellent at performing procedures. They're definitely around. Referring to them will ensure that the removal is done cleanly. All of these procedures are covered by medical insurance, so there's no financial burden. However, there are cases where only 1 or 2 areas are protruding. In such cases, it can be a dilemma. Opening a flap seems excessive, but doing nothing doesn't feel right either.
When there are a few sharp protrusions scattered, and the discomfort goes beyond "let's monitor it during treatment," the question arises, what should we do in such cases?
Here's an example. After extracting wisdom teeth, the lingual plate can sometimes become sharp. While it typically heals well if left alone, curious patients tend to poke at it with their tongues repeatedly. As they press on it with their tongues, the flap becomes thinner. And if it protrudes outward, they often complain about it. This can also happen on the labial side during orthodontic treatment. Such occurrences usually happen within the attached gingiva. In these cases, we could manage it without anesthesia.
Without anesthesia?
Wouldn't it be better to use at least a little anesthesia?
You can use topical anesthesia if you'd like, but patients typically don't report any pain. It's not painful at all, so just a light touch will suffice. In this case, a carbide burr was used. Connect a round diamond burr to the high-speed handpiece. And as you can see, without any anesthesia, simply smooth out the slightly protruding area. Then, with some bleeding, secondary healing occurs very cleanly, eliminating complaints. You can check by feeling it with your hand to ensure it's adequate.
This method provides an easy resolution.
It's definitely doable.
Personally, I'd opt for anesthesia.
In this case, some practitioners may hesitate because of the presence of the lingual nerve on the lingual side. Hesitation is understandable, but the lingual nerve doesn't protrude outside the bone or flap. So, you only need to work carefully in that specific area. For exostosis or slight protrusions that occur during orthodontic treatment, there aren't any significant anatomical constraints on the buccal-attached gingiva. You can address it simply.
There's no risk of entanglement between the gingiva and anything else.
If there's free gingiva involved, it could happen, but most cases involve attached gingiva, which is typically wide and thick in patients prone to such issues.
It seemed complicated at first.
But it turned out to be surprisingly straightforward.
Next, we'll discuss one of the more frequent procedures that orthodontists refer to as impacted canines. Impacted canines are particularly common, although we also encounter premolars and other teeth. To facilitate forced eruption of impacted canines, we often perform uncovering or window opening procedure. We've prepared a video to demonstrate this type of case. Here, we have an impacted canine, the number 13. The incision line is crucial. Typically, when making an incision, if you use a sulcular incision, I believe that's not appropriate. Do you know why? Sulcular incision can cause the wire to go underneath the flap. When the wire is beneath the flap, pulling the wire for forced eruption later becomes problematic. The wire won't move smoothly because it gets twisted, and fibrous tissue or soft tissue may get caught in the process. In the past, when I didn't have much experience, I tried this approach and ended up performing a second surgery to fix it. That's why I always use a different method. This method is called a semilunar incision. There are various names for it, but the incision is made in an arching shape above the tooth. As I mentioned earlier, incisions should always be made from posterior to anterior.
Despite having worked on numerous impacted teeth, I didn't realize it.
Here, I make the incision at the top to create proper exposure. Expose the flap adequately in the visible area. As you can see, I avoid involving the free gingiva and carefully lift the attached gingiva above it. Why? Because it's tightly adhered to the bone, it will tear during suturing later. By gently elevating it, suturing becomes much easier.
Is there a tip for properly elevating the flap? Is that too basic a question?
Well, it's actually a good question. To elevate the flap effectively, you need a precise incision. The key is to ensure the incision is clean. According to the textbook, the blade should initially enter vertically until it touches the bone, then rotate slightly, following the bone upward. Once you reach the top, the blade should exit vertically again. However, it never works quite that perfectly in practice. It is because our bone is uneven. So when you make an incision, some parts of the bone will be in contact with the blade, while others won't. Here's my tip. In cases like this, where the incision is small and simple, you can make a clean cut. Feel the bone with the blade and follow it along as if you're scraping the bone, not cutting the tissue. Just think of it as scraping the bone and go along. If that's not enough, you can go over the same incision line a second time, which makes flap elevation much easier. When the flap is elevated, most impacted tooth exposure cases are similar. Once the flap is opened, you can usually see the impacted canine underneath. If there's a retained deciduous tooth, remove it as well, following the standard protocol. Once the retained tooth is removed, the impacted canine becomes visible. To demonstrate bone removal, I prepared this case. For bone removal, both carbide burr and diamond burr can be used, but I recommend using the carbide burr, as it works well with both high-speed and low-speed handpieces without causing any major issues. I emphasize that high-speed handpieces carry the risk of emphysema, but the reason you should use a carbide burr more often is that when removing bone with a carbide burr, you can distinctly feel the difference between bone and tooth through your fingers. Bone feels like it crumbles softly as you work on it, whereas when the burr contacts the tooth, it produces a sharp and bouncing sensation. However, with a diamond burr, the sensation between bone and tooth feels almost the same. This is because even when we perform tooth preparation, we typically use a diamond burr instead of a carbide burr. Therefore, whenever possible, I recommend using a carbide burr for bone reduction in the upper region. Once the bone reduction is complete, to remove these soft tissues, you can use a diamond burr to carefully tap and clean them thoroughly. After that, since you'll need to attach a button, proper bleeding control is essential. Then, use an electrosurgery device for hemostasis, and completely remove any remaining soft tissue in the surrounding area. Absolutely no bleeding should occur. If hemostasis isn't achieved, it becomes very challenging. However, once bleeding is controlled, the process becomes significantly easier. Next, perform etching as per standard bonding procedures, ensuring thorough etching across the surface. Afterward, perform irrigation and apply the bonding agent. The surface turns white. Then spread the bonding agent evenly across the area and cure it thoroughly with a light curing device. Attach the lingual button securely and cure it using a light curing device. Here's a tip. If it falls off, you'll have to redo it. My personal trick is to use flowable resin. Not the expensive kind, but the affordable ones you can find at places like CDEX or other dental exhibitions. Use the resin to etch the area and ensure it covers the margins completely. Once applied, cure it thoroughly with a light curing device. This method prevents detachment and keeps it secure for a long time.
It seems similar to the technique used to ensure brackets stay attached.
If the attachment comes off entirely from the tooth surface,
There's no other option. To avoid this, proper isolation is crucial. Prevent water infiltration and maintain excellent bleeding control.
You're doing it yourself? I personally fabricate the wire before sending it.
For any requests, I approach them with a service-oriented mindset, ensuring the best possible results. Here's a tip for the intermediate stage. Use an explorer to twist and create a small space where a power chain or super thread can be attached.
이렇게 쭉 꼬아서 만들어집니다.
If there are any protruding parts, trim them down slightly. As I mentioned earlier, if the incision is made in the site with a significant undercuts, it can cause the wire to slip underneath, preventing proper orthodontic force application. This is why I strongly recommend accessing through a semi-lunar incision above the area. After ensuring the area is clean, apply additional light curing for extra security. As you proceed, silently pray, don't fall off, and then complete the suturing as per the standard protocol. Here's how the suturing process is completed. While suturing, it can be a bit troublesome due to the wire constantly getting in the way. A wide needle holder needs to pass through, but it often gets stuck. Despite that, make sure to suture appropriately. If sutures are placed too densely, it can lead to increased swelling.
Is it because of pressure?
If you suture too tightly, hematomas may develop, exacerbating the swelling. Most of these procedures are performed on younger patients, and as mentioned earlier, their healing abilities are remarkable. It's better to allow some minor bleeding. And look at what I am doing next. Now, addressing the dangling issue, etch the surface but skip the bonding. After thorough etching and rinsing, apply resin directly to stabilize the area. This approach minimizes discomfort for the patient in their daily life and allows the orthodontist to easily remove the resin later during the orthodontic treatment. And that's how the procedure is completed. This concludes the video demonstration of the uncovering procedure for orthodontic treatment. Lastly, I've prepared an additional topic, a digital approach to apicoectomy.
A digital approach to apicoectomy?
Yes, that's correct. In the case of implants, digital technology is frequently applied to surgeries. However, I'd like to emphasize that digital approaches can also be utilized for other types of surgeries. This patient is an 18-year-old who has been under my care. About 7 or 8 years ago, when this patient was quite young, the root of tooth number 46 wasn't fully developed. Due to severe decay, crown treatment was unavoidable. The procedure involved MTA filling to complete the treatment. Later on, as slight crowding began to appear, the patient wanted orthodontic treatment. However, after several years without follow-up for about 6 to 7 years, we took a new X-ray and discovered a lesion of considerable size had developed. Then I'm curious about how orthodontists typically handle when a lesion is present.
I see the evidence that the number 8 tooth have been extracted. Before extracting the wisdom tooth, the first instinct might be to proceed with extraction of number 6. Of course, this depends on the prognosis. As we've discussed in sessions 1, 2, and 3, I can consider cases where the tooth may be pulled. I cannot see the other options.
Procedures like apicoectomy or re-endo seem unlikely in this scenario.
Instead, refilling with MTA would likely be the recommended approach. Since it wasn't an MTA sealer but fully filled with MTA, re-endo wasn't feasible. In cases like this, the options for saving the tooth are quite limited. It had already been extracted when the patient came to me. Apicoectomy was the only option available in this case.
Performing apicoectomy on posterior region is particularly challenging.
Yes, due to limited access, poor visibility, and the complexity of the procedure. This is where digital technology can be incredibly beneficial. Typically, in digital guides designed for implants, the sleeve is positioned to align with the root sectioning site instead of a tooth. Using this alignment, a guided stent is fabricated, and the drilling can proceed directly along the guide.
드릴링을 하면 돼요. 드릴링을 하면
The drill then precisely sections the tooth effectively, leading to the apicoectomy in an accurate manner.
That's all you need to do, just drill, right? Only drilling can remove the tooth itself.
Yes.
After performing an apicoectomy, it's essential to ensure proper apical sealing using MTA. However, in this case, since the root was already filled with MTA, there was no need for additional sealing. The main goal here is to maintain the tooth for orthodontic purposes, with the goal of it lasting as long as possible, ideally until adulthood. Once the procedure is completed, the site can simply be closed. There's no need for additional bone grafting in this instance, because the cortical bone is quite thick and the defect is a concave area containing bone. Just closing the site is sufficient.
Is grafting not necessary in this case?
Of course, bone grafting is an option and is covered by medical insurance. Performing apicoectomy in this way allows for the materials to be billed, but not the surgical procedure itself.
However, this seems like an excellent idea.
Utilizing digital tools for apicoectomy, whether for orthodontic purposes or other dental treatments, is a valuable and versatile option.
Can a company provide such a guide if requested?
의뢰를 하면은 뭔가 저렇게 만들어 줄 수도 있나요? 아니면 본인이 직접 이거를
Or did you personally design it?
Yes, I designed it myself. Since I handle CAD/CAM processes, I can create and customize it exactly as needed.
And print it out at the clinic.
While implant companies might not typically produce something like this upon request, if you have a strong rapport with them, like with OSSTEM, they might accommodate your needs. Building a good relationship often opens doors, and there's no reason not to assist with something beneficial.
That's right.
Yes, this truly seems like a refreshing procedure.
It's currently a trending method among those practicing digital dentistry. It's widely practiced, and honestly, I didn't come up with this technique myself. It was actually shared by other doctors on Facebook. I have to credit Dr. Han Jongmok for this case. I saw his case, sought his advice, and then gave it a try.
In orthodontics, placing screws is one of the only similar instances, isn't it?
So, this concludes what we've prepared for today's session. It's been quite a journey through 10 episodes, and we'd like to express our heartfelt thanks to Dr. Choi Yong-kwon for accepting our sudden invitation and joining us today. Let's give him a round of applause. Thanks to you, we've learned a great deal about the essential surgeries involved in orthodontic treatment. Dr. Choi, how was your experience with us today?
It was a delightful time, and I truly enjoyed exploring this great studio. And today's the final episode?
That's right.
It's such an honor to be part of this grand finale. Thank you so much.
We were honored as well. Thank you so much.
I think the three of us really clicked today.
It was a great dynamic. It would be wonderful to team up like this again as a trio.
If we invite you again, would you be able to join us?
Absolutely. Feel free to call me anytime.
Once again, a big thank you to Dr. Choi Yong-kwon. To be honest, when we first started planning Ortho Barista, the goal was to make it a 10-episode series. So, today marks the final episode of this series. Are you feeling a bit sad about it?
Yes, I really am.
Well, here's some good news. We've been approved for additional episodes. We've prepared even more orthodontic stories to share with you all. Please continue to show your support for Ortho Barista just as you have so far, and we'll do our best to come back with even better content.
If you revisit episodes from the very beginning, we'll be back.
This has been Ortho Barista. See you again next time. Thank you. Shall we shake hands? Thanks to you, we wrapped up the final episode so smoothly and comfortably.